Welcome to the Stronger Together podcast, brought to you by Sandpoint Strength and Conditioning. I'm your coach, Kenny Marquardt. Today, I am joined by Sarah Adair from Revival Wellness Clinic here in Sandpoint, Idaho. This will be the first foray into something I've been wanting to do for a while, but talking to subject matter experts about things that are on the forefront of health, wellness, longevity, and kicking ass forever. Sarah knows all the things I do not, and that's awesome because I am a moron in this topic. I'm aware of these things. I know people on them, and so I get to ask all the questions that hopefully you have, but we're too afraid to ask. So Sarah's going to help provide us that perspective as a practitioner and subject matter expert, and I think you will enjoy this conversation. Bear with them. It's like towards the 45-minute mark. My internet just exploded. So we kind of had to pick up where we left off at a clean break. But I think you'll enjoy it anyway. All right. See you. Sarah, how are you?
Great. How are you today?
I'm doing very well. I'm very excited for this conversation, transparently. So
Great.
no pressure. No pressure at all.
Fair enough.
But as we were talking about before I hit record, like I really don't know enough about this. So this is going to be a good experience for everyone to hear me learn, and they're going to learn a lot as they go. Yeah, before I get too far down that road, tell me who you are, what you do, and where you do it.
Yeah, perfect. So I am a nurse practitioner. Started as a registered nurse. I've been in the industry for 15 plus years. Went back to get my master's in 2017. A lot of my background has been in emergency medicine, but transitioned over to more preventative and functional type medicine. I learned a lot in the emergency room setting, but wanted to get back to prevention instead. So that's when I opened up my practice, Revival Wellness Clinic. Our first location's in Hayden, and recently just opened up in Sandpoint, which I'm super excited about. And I like to focus more on the whole person when I'm treating somebody. I kind of dive into their habits, their background, their preferences when I'm coming up with a treatment plan for them.
And then as far as treatment plans, what is that? I'm sure that could be a wide-ranging set of options.
Yeah.
But like, what does that typically comprise, or what's a majority of your people?
Yeah. So when I'm having a consultation with somebody, my first question is always, what are your treatment goals for? So if it's, I want more energy, or I wish to lose a few more pounds, or I want more strength in the gym, or I want better recovery, it depends on what their goals are. And then that way I can tailor their treatment plan to them specifically. I would say a majority of my patients are on hormone replacement, and a lot of that has to do with a wide array of symptoms and treatment goals. And then I can kind of tailor with additional medicines. I do see people for medical weight loss. So sometimes those go hand in hand. So I'm combining the two often.
Yeah. So this is again where this is going to be good because I'm aware of it obviously, but the other side of it not much at all as far as the knowledge. But I actually want to go into the female side of things first, just because I think that's so. Men have been on testosterone since I don't know. I was in the gym. That was like when I started in the gym at 12. Like I knew people that were using exogenous hormones. So. But the female side of things, that's a relatively new frontier, not frontier. And I vaguely am aware of the history of why that has been contraindicated that was turned out to be faulty. But anyways, before I prattle on with stuff I don't know, tell me about female hormone replacement therapy. Who's a candidate? What's their symptoms? What the outcomes? Just dump it all, please.
So yes, like you were kind of alluding to, I mean, there were hormone replacement for women back in the day. Maybe not as common as it was for men with testosterone, but it was more synthetic versions of the type of medicine that was more mainstream, I would say. Then they had that Women's Health Initiative study that kind of put us back decades in as far as women's care. But there were some good things that came from that study showing that appropriate hormone replacement for women can actually be very helpful and prevent chronic disease. So I think we're getting back to that space where we're trying to find more good data supporting hormone replacement for women. And by that, I mean bioidentical. That's the safest version for women to be on. And it's actually very helpful. Now, there's very few women we have to be cautious with as far as replacement. And those are with those that have either a personal history of estrogen sensitive breast cancers or an immediate family member, so a first degree relative. That being said, they can still use some forms of estrogen usually.
And that was essentially what that study was. I'm not even sure that it showed that, but that was kind of what was propagated from that, and why there's so much hesitance to have women on hormone replacement
Yeah.
therapy
Well, and
subsequently. Correct.
that study used synthetic versions of hormones too, so that has to be taken into account.
Right. But
Yeah.
so that was like, I mean, it was like a major taboo. Like, do not do this. You
Yes.
will give women breast cancer if you put them on exogenous
Right.
hormones,
Right.
which is
Not true.
not true. Correct.
Not true.
Okay. I think that needs to, like, when I listened to some podcasts about it, I read about it, this was pretty gross to me in a lot of ways. And I don't mean gross. It just kind of was like really unfortunate, because
So sad.
what I'm sure you're going to elaborate upon is the massively positive impacts that this hormone therapy can do
Hmm.
for perimenopause, for general health, for a lot of things. Again, I'm going to get in the weeds. I'll let you go there.
Yeah.
But there seems to be a ton of tremendous benefits from this,
Yes.
without having the propagated negative side effects that were
Yes. Yeah.
stated.
Yep. So so starting with the class of perimenopausal women, that's the ideal time to start hormone replacement because that's when our hormones are starting to dwindle and we're not producing as much. And I do want to point out too that testosterone is part of that for women too. That often gets missed, unfortunately. And it's a very big part of our overall health, just like it is men. So that's what I'm looking at usually in the perimenopausal phase, is replacing a couple of those things, again, depending on what their concerns are, what their symptoms are. And that's also how I guide treatment. But then as we get into, and perimenopause for some women can be as short as 12 months. It can be as long as decades. And so I think, for those that start perimenopause younger, unfortunately, I think we miss some of them because they think they're too young to be going through it, which is not necessarily true. So that's the best time to start it. And then as you go into official menopause, then you're continuing on that care. And sometimes dosage forms can change, dosing can change, but that's something, that you're discussing with your provider who's providing it to you. But by doing that, one, you're providing symptom relief. So for a lot of women that are going through the perimenopausal phase of life, there's a slew of symptoms, but most commonly it's hot flashes, poor sleep, mood changes, changes with their periods. Weight gain is a huge one. And then lack of libido is another big one. So I'm dealing with treating those symptoms. But in the big picture as well, when you're starting these medications in perimenopause, you're also preventing long-term disabilities or chronic illness. So things like osteoporosis, helping us maintain our muscle mass, helping us maintain our brain function, preventing dementias, preventing urinary tract infections. That becomes a big one as we get older. Lots of disease prevention when you're optimizing your hormones as well.
I'm not a woman, if you can tell.
Can't do that.
Just put that out there. So this is, again, largely speculative. I want to try and like address this as openly as I can. But how many women just assume that that's a part of life, not knowing that there is something to be done about it? You know what I mean? Like that seems to be something like, so I'm
Yeah.
40, the generation I watched grow up, or my parents say, like it seems like that was just like what you did. Like that's kind of how it was. And you heard all the stories. I don't know, not all the stories, I guess, probably didn't, but like,
Yeah.
it doesn't sound fun.
No, I would say women in the age group, I mean, I don't know that I have definitive numbers on that, but women in the age group currently in their 50s, 60s, and 70s is when that hormone replacement became taboo. And so there's those 3 decades, I would say a majority of women think that this is normal. As more and more people are talking about it, it's out in the media, social media and all that now, we're going to catch the younger generations, which is good because that's when we should be starting them on replacement. It's not to say that it's not to say that we still can't get that group that was lost in that time frame back on hormones if that's, something that they want to consider. It's still safe for them.
What's like, again, this is going to be a general answer, I'm sure, but like at what point would it be worthwhile for someone to start pursuing this or considering this?
I would say if you think you're having any symptoms of perimenopause, and again, those symptoms can be widely different across every woman. But typically what I hear is the common ones that I just mentioned not a couple minutes ago, but it's also just this sense of overall, I don't feel like myself. That's what I
Oh,
hear frequently. Nothing's changed. My diet's the same, this, that, my life, blah, blah, blah. But something just doesn't feel right.
oh.
And that's usually when they start searching.
Do you have a rough age? Like when's like when's too young? Is there a too young when someone's like
No,
this doesn't make sense.
no,
You're
I don't think there's a too young, but I would say on average, most of my women that I'm treating perimenopausally are in their early 40s.
got it. And then obviously it's not a they walk in and say, I don't feel like myself, and you say, here's all these here's some drugs. Good luck.
Yeah, no. It's what are your symptoms? Let's be specific. When did this start? Tell me about your lifestyle habits. And, I'm getting as broad a picture as I can. It's including lab work so I can match up what they're saying with how I can treat them.
And then you do lab work.
Yes.
Like that's yeah.
Yeah.
Do you have like is there standard levels and numbers and like that what people would see on a generic annual exam
Yeah,
that would
it's a
indicate
great
them?
question. So I get a lot of people that have come from their primary who have gotten the labs, and sometimes that's a little trickier than not getting those from their primary or whoever, an OBGYN, and they hear, on follow-up from that provider that everything looked normal.
Mhm.
It certainly does if you're looking at the blood work and they're following within that normal range per the lab, but I'm interpreting those labs much differently, and I often work outside those ranges oftentimes.
Is that in like an optimal sense or is that a symptomatic sense? In other words, like there's a range that's you're not gonna die, but
Right,
there's a
right.
range where you probably feel a lot better.
Exactly. So I tend to work on over the upper limit of normal for a lot of things. So testosterone, for example, is one of those that oftentimes is out of range, but that's when people feel most optimal. So, and I'm okay doing that. Yeah.
And then what do you see from people? Like I know you touched on the resolution of symptoms, but like what do you tend to see from people as you tweak dosages, as you make modifications, as they start their treatment? What does this look like for somebody?
Typically, so when I'm following up with men, typically in the initial follow up, which is usually around 2 months after starting therapy.
Sorry, can I? So I want to do the men in this. I kind of want to do the whole like life cycle. I don't mean to interrupt you, but
Oh, okay.
what is it? As a female, like what is it like? So you're experiencing these symptoms. Like how long? What's the duration of the onset of resolution of these symptoms? Like how's
Yeah.
that?
So typically, I'm starting them because women have definitely more moving hormonal parts than men do. So I'm starting them off any patient low and slow. But usually at that follow up, which is around 2 months, they're already starting to feel more energized, better sleep, better libido is usually what I hear. As they continue on with treatment around the 3 to 6 month mark, it's continued improvement of energy, it's improved brain fog. And then around the 6 month mark is when I'm hearing the body composition changes, decreased body fat, increased muscle mass, and that, you continue to build on that.
Does that once they begin a course of exogenous hormones, are they on that forever?
You don't have to be, no. And I tell my patients, as long as you feel you're benefiting from the medication, you can be on it lifelong, assuming you continue to have a healthy medical condition overall. Obviously, if there was a major event, that might change things, but no, you can be on it for as long as you want.
Well, how extensive is the research for like a 50-year course of exogenous hormones for somebody? Do you know? I
Yeah, I
mean,
don't know that.
that's extreme, but
Yeah, I don't know that we have that data per se because of that huge chunk of time that women, due to the Women's Health Initiative study. But there are new reports coming out on more on long term. There was a new one for men. I don't know that we have one for women per se, but that showed, you know, decades of being on the medication, there's no increased risk of negative events.
yeah. I mean, again, from my perspective, the bone density and sarcopenia, like that, all that would be such a massive life, not only life extender, but life quality improver.
Yeah.
You're going to be less worried about slipping on the ice, breaking a hip, and ended up in your death sentence, riding out your days in the
Right.
home.
We know, I mean, osteoporosis, which increases your risk of fracture. Fractures are a huge part of why the elderly population, as far as trauma, it ultimately ends in their demise, usually within a year. It's a high percentage, unfortunately. So yes, if we can prevent that and improve recovery, even if it did happen, that's a win in my
Yeah, that's a wild set of statistics that I've seen.
Yeah.
Like that's a it sounds like the first time I
Scary.
heard it, I had to rewind the thing and then be like, hold on a second.
Yeah.
What did you just say? The survival rate, the 5-year survival rate was like less than 50%
Yes.
after a
Yep.
broken hip. I was
Yep.
like, wait a minute, it had nothing to do. But anyways,
Yep. And same, so specific to women, it correlates with urinary tract infections. As we get older, our rate of urosepsis, which is sepsis related to urinary tract infection, increases. And a very, very simple prevention method for that is topical estrogen, which
huh,
is cheap. Most insurance covers it, and it drastically reduces the risk of urinary tract infections.
awesome. I
Yeah.
mean, yeah. What's your recommend? This kind of I want to kind of bleed what we're both doing. What's your recommendation for women in terms of fitness? Like, do you see things change in that regard as
Mhm.
they start to supplement more with a fitness regimen? And then what do you see as being best in that realm, if
Yeah.
you can say?
Yeah. So, I mean, always a good combination of cardio and resistance training, but resistance training becomes a big part when we get older to help maintain our muscle mass, which maintaining muscle mass is the most important because that helps maintain our bone strength. And so I do like to promote cardio, but I more so like to promote resistance training. It's not saying you have to do, crazy things in the gym 7 days a week, a couple of days a week to help keep your bone strength and your muscle strength will greatly reduce your risk of those complications we see as we age. Even just simple being able to do your daily activities of daily living significantly helps if you're doing a little resistance training.
Yeah, good. I'm glad because,
Yeah.
like I
And
said,
along with that,
this. If we came in
proper
blind here, if you would have said something totally opposite of what I believe, that would have been it would
you're
have
like,
just been what
oh,
it was. But
nah.
no, I 100% agree with
Yes.
what you just said.
Yeah.
Both for the bone, we've seen a resolution of osteoporosis
Hmm.
many, 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 many times where people are like,
Yes.
holy, like I'm not on any drugs. I just did. And this is what we've seen. Like they just went and their doctors were shocked at what they'd been able to fix by just getting
Something
under a little bit
super
of load.
simple. Right, right.
Yeah.
And if and if a person feels more comfortable with the guidance of a trainer, by all means. Like myself, I just have a little set at home. I even do resistance bands. You can do it in the comfort of your own home too. Just be doing something, I think.
The if you don't use it, you lose it thing is also really relevant in the range of motion, whether resistance add as much weight as you feel comfortable with, but more so
Yes.
the continuing of utilizing your range of motion.
Mm-hmm.
Like I've
Mm-hmm.
seen the same where it's like if you keep doing it, there's no reason it's going to go away, which is something I have a hard time communicating or forecasting to people to say, hey, look, like you're not going to be able to like tie your shoes. You're not going to be able to pick
Yeah.
things up off the ground. Like all that stuff's
Yeah.
going away if you don't continue to
If you don't do
practice
it,
it through repetition. Yeah.
stretching, yep, all that.
Yeah.
Yep.
Okay, cool. I know
A
we
big part of that too is proper diet. You've got to feed your body. You need protein. I think that's a hard one for people to be sure that they're consuming enough protein. That's what feeds your muscles. So, and ultimately keeps your body fat percentage in as where it should be.
yes. What's your recommendation for folks in that regard?
Well, it's weight dependent, right? Obviously, a larger man's going to need a lot more than a 140-pound person like myself. I try to encourage, especially women, to consume at least 100 milligrams if you can, and that's start with that because for some it's a challenge. I'm starting from very little protein sometimes, so I'm trying to work up to that. Obviously, women who have been in that scene and are doing all that themselves, they tend to do pretty good. But I think nutrition is a huge gap, knowledge gap. And when I'm telling people, and they're trying to calculate, oh my God, I feel like I'm just going to be eating meat all day. Like, well, there's some alternatives. Here's some ways to sneak in protein, and you're not feeling like you're eating all day. But there's little tips and tricks we do nutrition counseling with our patients.
Well, that's that. So first of all, I'm really glad to hear you say that because again, same page. I say a gram per pound of lean body weight, but that usually puts them around that 100 grams a day, which I'm not sure if it's
I'd say ideal body weight.
yeah.
Yeah. I don't know if you said that. Sorry, you might have, and I didn't hear that.
Well, no, I'm not sure that I did either, but I think the point is like that people thinking 30 grams per meal, like they look. I think that this is something where I'm 205 pounds or something, and I do have quite a bit of muscle. I think I wonder how many women look across the table at me when I make that recommendation, and they're like, "You're an idiot. Like you're a giant man. Like you need way more protein than I do. You don't. This is not
That's true.
relevant to me." So, but to hear it from you, to echo what I'm saying, I think is helpful. And again, it's part of what you said though is like you do kind of feel like you're eating all day, which is a little bit of the magic in it. Because the other stuff, like I think most people could probably eat half a jar of peanut butter because it's delicious, but it's also quite calorie dense
Yeah.
because it's all fat.
Right.
But protein is a little bit more arduous to get through. And so you do tend to feel more full. You do tend to
Yeah.
slow down a little bit and blah, blah, blah.
That's where I feel it's a little bit of a challenge when I'm getting feedback is because protein is very satiating. And so
Yep.
your body's like, wow, I'm full. And then, full for extended periods. So if you can break that amount up, I think is helpful sometimes.
Yeah, 100%.
Yeah.
We could probably do all three of the topics I wanted to get into today for an hour apiece, but I would love to transition into the male side of things.
Sure.
So, by the way, if people have follow up on any section of this, like I'm sure we can have this conversation again or dive into any of these things. So
yeah, absolutely.
Send me feedback or us feedback. But
okay.
Let's talk about men. So similar set of questions. There's we don't have the phase of life that women do necessarily, but we do tend to start losing testosterone or like a little bit after 30.
Yeah, it's actually so women go through menopause. The term for men is andropause.
Got it.
So yeah, they start going through andropause sometimes as early as 30. Unfortunately, I'm seeing it younger, and I think that's it can be a plethora of reasons. But yes, historically, the drop starts around age 30, and you lose 1 to 3% each year after that of your total. So if you started off low for, again, whatever reason, then you're kind of already behind the 8 ball. And so those people tend to feel symptoms more intensely, I would say, at a younger age.
And what symptoms would those be?
I would say the biggest one I hear from men when they're looking into their hormones is fatigue is a big one, especially like an afternoon type fatigue. Like they'll wake up feeling okay, and then just by the end of the day, they're wiped out. Another one can be lack of libido or changes with erection quality. Another big one is they feel less strong. Like even though they're working out, they're not making the gains that they feel like they should be in the gym. Weight is a part of that. So switching muscle for fat for some. And then a big one's lack of motivation in their job, their families, whatever the activity. And brain fog is a big one. Just feeling like they're not as sharp as they were.
Yeah. So that's just not a part of life. You don't just decide like you start to go sliding over the hill after 40 and you're just,
Well, I mean, you can choose to kind of work around it, or you can choose to feel better.
Well, yeah, sorry, that was a bit of a like facetious question, but it's the same. I get the same stuff in the gym where like I'm never going to be what I once was. I'm like, well, yeah, I guess not with that attitude. Like
Sure.
we can make some improvements if you want. You might not be 20 ever again, but
right. Yes, and thank you for saying that. Yeah, when guys are looking into testosterone therapy, I feel like there's either this idea that they're going to be some huge Hulk figure, but it's no, I'm wanting to replace the amount of testosterone you require to feel well. So that could be your dose is different than this man's dose. Every man's different. Some require less, some require more. Getting you back to where you feel better. Am I going to make a 60-year-old 20 again? No, that's not my objective. It's to make you reach your treatment goals, realistic treatment goals.
So you mentioned there's a couple of questions I had from that, but one that you mentioned that I forgot to address on the female side of things is that taking testosterone is not going to turn them into a man, nor is it going to turn them into some sort of like She-Hulk, correct? No. Okay, thank you.
No,
just like lifting weights, not going to do the same thing because I get the same question. Like, I'm going to get bulky because I lift weights. I'm like, no, you're not.
No. No. With proper dosing, no. And, women's testosterone dosing is a fraction of what men's testosterone dosing. I take testosterone. I think I still look like a woman. So, yeah.
Yeah. No, I know quite a few women. I take what I say for what it's worth. But I think hearing it from you is all the more impactful. But it is not. It's the same like I see. Like I've had so many women come in and say, if I start lifting weights, I'm going to turn into a man.
No.
Nope.
No.
That's very challenging to do. You can probably... You want to become a female bodybuilder, that's a very challenging course of action,
yes,
or path to take, but you can, but it's a lot of work.
And
it doesn't happen accidentally.
Yeah. And there are some bodybuilding women that I treat, and of course they require a little bit more testosterone because they're burning through it.
Yeah.
But the average woman who's using it for symptom relief, yeah, so we're small doses. Yeah.
Yeah. Thanks.
Yeah.
Okay. So back to the men's side of things. You referenced low levels, and I've had a hard time getting clarity on what low is and whether or not it's relative to the individual
Mhm.
over the course of their life.
Yeah. So, when I'm and this goes kind of back to the lab reference ranges. Some labs, the low end of normal will be 200. For some, it's 300, so anywhere between there. And then the upper range can be anywhere from 700 to 1400. So it's a huge gap on what's considered normal. I would say on average, when men are coming in to me, their ranges can be anywhere from I would say 3 to 500 is usually, and of course, there's outliers on that end. But as long as when I'm checking reference ranges and as long as you're symptomatic, that's what I'm trying to treat. And it relates to testosterone, then I'm willing to try and treat your symptoms. Now, if we started let's say your testosterone level was 500, we got you up to a decent value around 1200 or whatever, and you're like, I just don't feel different or, you know, anything different, then I might explore different avenues. Okay, is it your thyroid that we need to dive more into? Depending on the symptoms, is there something else we're missing that
Mm.
we didn't see initially? But usually it's the lack of testosterone in men that make them are symptomatic, and then once replaced, they feel significantly better.
How long of a data range, like in regards to a decrease in testosterone versus a example of one, like do you pay, what does that look like? Does it depend on the age of the patient? Does that make sense? You know what I mean? Like if you came in on the lower end of age and had a lower-ish range of testosterone, would you be more interested to see what another reference range would be, or would it be treatment of the
No,
symptoms
yeah,
therein?
same reference range. I'm using the same reference range despite age. If somebody's coming in a little bit younger, then there's a little bit more lab work I like to do to be sure that there's not an anatomical issue causing it. When specifically looking into the pituitary gland, if you have, and there's a couple labs I like to check on younger patients. I actually check it on all patients, but specifically younger patients, and they're coming in with low testosterone levels, I'm making sure that there's not an issue with the testicles
Hmm.
themselves or an issue with the pituitary gland. If there is, and those labs, suggest that, then I'm sending them off for further treatment because testosterone replacement, yes, will be part of their ultimate treatment, but they need to be sure that there's not something going on that needs a specialist.
Got it.
Yeah.
For I'm going to say normal, healthy male. What ages are you seeing? How young is too young for this? I guess
My
or is there
youngest
such a thing?
patient is 21
Okay,
and my oldest is in his 70s.
and there's no pre-existing condition in the 21-year-old.
Well,
Let's keep it anonymous and vague,
There was
etc. But
there was an explanation for his low levels that made sense to why his levels were that way,
got
but
it.
was still able to start him on treatment.
Okay, and I think that same question I asked about the female. At what age should men start to pay attention to this in terms of blood work, or just go start to
Go
get
check.
checked? Yeah, because
Yeah,
it's not. This is not a normal part of my panel that I get. I don't
right.
think.
Yeah. It's
Yeah.
often not. You have to ask for it. So for women, I would say, perimenopause can start as early or as young as early 30s. So around 30 is the youngest I've seen. But on average, it's usually around 40, 45. But I would say to them, if there's any trouble, especially around that age range where they're still maintaining fertility, I would encourage them into looking into their labs. If they're unable to maintain a pregnancy, if that's their wish to get pregnant, or their periods have changed
Hmm.
in any kind of sense.
Okay. And then how about for males?
Males, and that's a little bit tougher because there's not
Yeah.
like outward signs. It's
Yep.
more subjective feelings. So I feel tired and I don't know I shouldn't feel tired, and it's usually around, work. Like I've been doing this work for a long time and now over the last year it's different. Like I can't hang anymore, or a lot of times it's the gym thing. Like I should be getting more gains than I am and I have in the past. It's just not working. And then libido is usually always hormonally related typically. I mean, there's
Yeah.
other reasons for the lack of libido, but that's the first place I like to start.
Yeah, got it. And then in terms of like the amount of time, you said there were some studies on the duration of treatment for males, like for long-term treatment. Because again, same thing. It's more, as far as I've come to understand, like if you begin this course of treatment, you are probably going to be on this treatment for the rest of your life. Probably.
Yeah. If you feel a benefit of it, then yes, you can. I always educate my male patients, if for whatever reason you want to come off of this, then there's a protocol I recommend to do that safely, because there is a rare chance that exogenous testosterone therapy can cause permanent loss of testicular function.
Huh.
And so then you're not producing your own testosterone or sperm. And so that's also important for when I'm treating men who wish to maintain fertility. There's a different type of treatment I do for them, but they can still safely be on testosterone. And so if they wish to come off of it, then there's a protocol I use to ensure that their testicles come back to baseline.
What's the success rate been like that for that? I mean, again, there's probably, I'm not sure what the sample size is, but for people to come off of it with the protocol, and then I guess I was under the impression that once you began, if you came off, you were going to be in a pretty bad state of affairs.
No, I mean, you can stop testosterone therapy, cold turkey per se. I mean, I would say there's a safer protocol to ensure you don't shut down your testicles, but it's a very rare risk. So to answer your question, I can't think of a patient that has requested to come off of it, a male patient. There's been patients that have transferred their care elsewhere, for whatever reason, moving out of state or whatever. And I don't know if they ever came off of it, but I've not had a patient request to come off of it. But if they did, I would recommend the protocol and essentially start them on an additional medication for short term, 3 months, just to be sure that they get back to their baseline.
This is such a weird, I'm going to totally out my weird, which is not a great way to start this question, because it's not as weird as it's going to sound.
I'll let you finish.
Yeah, no. But I'm going to leave the listeners hanging here. So in terms of like a long time length of treatment like that, I think I get a little bit where I'm like, I don't know what's going to be happening in the next 10, 15, 20, 50 years.
Mm-hmm.
If the legislation changes, if my provider changes, if I move to another country, like what is that? That kind of freaks me out a little bit. Which again, that's not as weird of a question as I may have teed it up to be. But my paranoia is probably what I was leading into there.
That's hard because, I would say I hear often, unfortunately, that, a patient went to their primary care wanting to get on these treatments. Their primary care is not willing to do that for whatever reason. So, of course, come to clinics like myself. If it was an instance where, they had to move or whatever, I would ensure that that patient has enough medication to get through until they can find another avenue where they're moving. It's usually been women who have, transitioned their care maybe over to an OBGYN. Okay, let's make sure you have enough medications until, you see and follow up with that person. But I mean, same for women. If you wanted to come off of it, you can. The only time I would probably recommend coming off of it is if there was a big change in their medical status. So let's say they had, an unfortunate massive heart attack. I'd say, well, okay, let's back you off. Obviously coordinate with your cardiologist, something sentinel like that, a blood clot, some major event, then I would, halt treatment temporarily until that was dealt with and coordinate with those other providers.
Yeah, makes sense. Like I said, I think it was just a weird, just the thought process of being on forever, I think raises other questions, right? Like, just don't know. I don't know. Other countries may have a different, I'm not sure I'm going to live in another country. That seems a little bit bizarre of a concern.
But there's people that are on medicines for decades. This is no different, They're on blood pressure medicines or statins or whatever it is until their dying day. If this is just the same, it's just a different type of medicine. You're treating hormones.
Yeah, and I think transparently, I grew up in the gym in the early 2000s, and that was a big steroid era. Like that was coming off of, I think we were seeing the repercussions of the 1970s and 80s steroid era.
Yeah.
And so I think I have a little bit of a predisposition towards fear of these drugs.
Yeah.
Because of what we were watching from them. So again, I think there's a little bit of I have that have a bias towards
Yeah.
being a little bit more concerned about this stuff because of my exposure to that.
Yes. Yeah. And you're right. So, I mean, those testosterone bioidentical, a lot of those guys were on as their base. And I would say if you're going to use anabolics, you should always be on testosterone. But they are using super physiologic dosing. I mean, so on average, guys I'm dosing them anywhere from 100 to 120 milligrams to sometimes 240, sometimes a little bit higher, depends on the individual. These gentlemen, that are bodybuilding, they're taking 600 milligrams a week on top of their anabolics. Anabolics are not bioidentical. They are foreign to us. That is why they have those huge warnings with liver dysfunction, cardiac dysfunction, all of that. Those are foreign objects. Just like if you were to high dose anything else, opiates, whatever it is, those are harmful. And when I'm doing hormone replacement therapy, I'm not using super physiologic dosing.
Yeah, that makes a ton of sense. What are the downsides? Like, why would somebody not want to pursue this? I guess I'll stop there. Why wouldn't somebody want to do this?
So there's different forms or different ways to replace testosterone. So I would say the most popular and the most effective, for lack of a better term, is injectable testosterone. Some people, the thought of needles just is not a thing, and so I get that. The other options are pellets. With pellets, they're pretty convenient. Pellets, they are just little grains of rice, and they get injected with a minor surgical procedure, usually to the top of the buttocks area. And so those are kind of convenient in that you only have to do the procedure every 3 to 4 months, depending. And it's kind of like you get those in and then you can go about your life. What I don't like about those is the dosing's really difficult to manage sometimes. And you get this really great, rise in your testosterone level and you're like, I feel amazing for a couple of weeks. And then you start to dissolve those pellets and you kind of get this big peak and trough. So with using topical, which is the other option, or injectable, you're able to keep your levels more steady. Both are effective. It's usually a preference. It's a discussion I'm having with each patient on what their preference would be. Some prefer topical, some prefer injectable. It's just, I like to offer both.
But half-life or whatever maybe
It's
that's not the right
different.
term.
Yeah. So when you're applying it topically, you're applying that daily because it gets absorbed within that time frame. When you're doing injectable, you're injecting either into subcutaneous tissue or a muscle, and that gets slowly released throughout, over this couple of days. And so you're injecting, you can inject daily, you can inject a couple times a week, but that helps keep it more steady.
Yeah, it's more even experience than the pellet. Makes sense.
Right.
One of another, I think this is a commonly held, but it's a belief that you should prolong your initial onset of this treatment as long as you can. And I'm going to compare it to, which is probably not a fair comparison, but like a hip replacement, where like might as well wait until you absolutely need it because, kick it out as long as you can because technology is going to prove you probably don't want to do this again, blah, blah, blah.
Sure.
Is that the same thing? Again, maybe not a fair comparison, but same idea, like wait as long as you need to, and then when you need it, go for it?
I mean, you could, but, if you're experiencing symptoms, why not feel better sooner? I hear that often, actually, that, when men come in, they're like, I wish I would have done this sooner. I don't know why I didn't. And the other part of that is treating you in your preventable period. So that's around our 30s, 40s, 50s. Catching you in that time frame will help prevent these other chronic illnesses. So I don't necessarily agree with waiting until you feel like total garbage because we're missing preventing that osteoporosis, muscle wasting, dementia, all that stuff. We're catching that earlier.
Maybe divorce. Maybe prevent that too.
Yes, that's, in all honesty, hormone replacement. I've seen several marriages. It's helped. So
got it.
Yeah.
Yeah, super interesting. Okay, I think that's exhausting because again, I do want to get into the next topic here.
Yeah.
Let's talk about peptides. This is something again, no idea. Some acronyms, but that's about it. So let's explore the world of peptides.
Okay.
What are they? What do they do? Like the common ones. I think we should probably go there first.
Yeah. So peptides are just essentially a chain of amino acids, right? That's what a peptide is. A protein is a chain of amino acids. A lot of the peptides out there are from a specific chain of amino acids that is not foreign to our body. It's not unique. So for take example, BPC 157, I'm sure that's a very common one people hear. I like to actually use that in combination with TB 500. It gets better results, I think. I see that clinically. So both are a very similar protein, and what they do, kind of in, I guess, simple terms, is it's a potent anti-inflammatory, so it helps reduce inflammation at a site of injuries. And then it helps revascularize damaged tissue. And so I use BPC, or the combination, which is called Wolverine.
You say Wolverine, like the Marvel character?
Yeah, Wolverine
Okay.
peptide.
Sorry,
Yeah.
just
Yep.
wanted to make sure I heard you right. Before I started spouting that off and be like, you're an idiot.
What are you talking
It
about?
was not that.
Shush. So I use that. I use it for gut stuff, actually. So I used to treat it for GERD, IBS, Crohn's, ulcerative colitis, because it's unique in that it's formed from our gastric juice. So that's where that peptide originates. So it's actually been researched for quite some time regarding use in the GI tract, but then they saw the additional soft tissue benefits. So I use it for acute injury, chronic injury. I use it pre and post surgery, and have seen not awesome results as far as recovery, even with major joints like shoulder, hip, that kind of thing. And their surgeons are just floored by how well they're recovering. Whether they just decide to disclose what they're doing is their prerogative, but I do encourage my patients to tell them.
Sorry, the reticence to share that because traditional medicine is a little bit behind on this stuff, or because they're...
I'm surprised actually that I'm hearing more surgeons are aware of it and their hands are tied and that they can't prescribe it. So I have had some surgeons encourage their patients to reach out to clinics like myself to obtain it because they see the benefit of it. They just can't prescribe it themselves. So that's great. I'm hearing more of that. So I think that's fantastic. And the risks and benefits are pretty low comparatively. So again, because this is a peptide our body recognizes, there's very few side effects, if any. I've not had anybody have a reaction to it. I usually just hear benefit depending on what they're using it for. So that's great. To other medications that can have side effects. The other class, I would say the more popular class of peptides are called the secretagogues. What they do is tell your body to produce more growth hormone. So that in turn will produce more muscle, decrease body fat. It has an awesome positive impact on your immune system, your bone health for women and men. There's some anti-aging benefits with skin, hair, and nails. So I see that. I use that a lot in conjunction with hormone replacement therapy, but I also use it in my weight loss, with my weight loss patients too.
Naive question, but the growth hormone that I'm thinking of, again, coming back to the bodybuilding era, where like people are doing that, eliciting that response naturally versus exotic, like from external sources, that completely
Correct.
different.
Yep.
Those are very different reactions in the body.
Yeah. So
Okay.
HGH, like commonly used in the bodybuilding world, is straight up growth hormone. Omnitrope is a brand name for that. That is just giving your body the extra growth hormone, versus secretagogues tell your system that's already in place to produce more. It's sending a signal to produce more rather than just straight up giving it to them. So as long as that system's intact, and that's a pretty rare condition for that not to be intact, and you would know that from a very young age, you'd have an actual growth hormone deficiency.
Okay. Well, we left off on, if memory serves, is I was asking about growth hormone, and I was actually curious about how that pertains to tumor growth. And is that something, again, I may have made up or heard?
No.
Okay, good.
Yep.
Sweet.
So there is a potential risk, if there was an underlying cancer or tumor growth that we weren't aware of, either the patient themselves usually, and they use these, it could accelerate that tissue growth. So that's something that I discuss with each patient as well.
Okay.
But hopefully, sometimes, again, depending on your treatment goals, we're using these short term too for results. So that's also, keeping that in mind as well.
Yeah, fair enough. Okay, sorry, I know that was a large interruption. Where should we go from there? Sorry, you were going through a couple different classes and...
Yeah, so Those are, I would say, the most popular ones out. And there's other peptides that you can use in combination. I use a lot of the GLPs, which, is definitely more in the weight loss space, but they're technically a peptide as well. And so I use that a lot, short term to help people reach their weight loss goals. Of course, always talking about the foundational stuff, which is diet and exercise. That's when you will maximize on these medications. Same thing with the secretagogues. If you've got your testosterone optimized, you will benefit usually better with the secretagogues when your testosterone levels are up to par. The other types of peptides, and there's just a plethora. There's ones that can help with brain function. So help with neurocognitive dysfunction. There's ones that can help with like arousal and sexual libido. There's ones that can be used to even like increase the melanocytes in your skin, so tanning. There's just there's all kinds of different peptides. You can really go down a rabbit hole.
Yeah.
What can be difficult, HCG is part of that. I'm sure you heard HCG in the gym scenario. HCG is used quite a bit. I use that in the fertility space too to help maintain fertility, but you also can use it in the weight loss space as well. Using other things like NAD, glutathione, those kinds of medications as well, just for, again, overall wellness. I would say the difficulty sometimes with these medications is they're not FDA regulated. And so sometimes getting access to them can be a problem. I do always use compounding pharmacies that I trust and that have a good reputation, do purity testing, all of that stuff, are regulated for their compounding. But even sometimes, the FDA gets their hand in the mix and will take some of these off the market. And so that can be a challenge when there's a demand for some. Currently, it's HCG, only the commercial products available right now. So that continues to be a challenge. Probably will be for quite some time.
So is that partially FDA, partially the kind of surge in popularity in these drugs as well?
Yeah, I'd say it's a combo. They tend to pick on the ones, they tend to pull out the ones that are most popular at the time. So around Christmas time last year, around this time last year, it was a lot of the secretagogues and BPC they pulled. And they always say, they're checking, for safety and all that kind of stuff. But it's hard because a lot of these medications, pharmaceutical companies can't patent, and so there's not a lot of research done on them.
Yeah.
And so that's why they fall under kind of the research peptide world. And so there is a risk associated with that because we don't have a ton of studies like we do other, medications made from the big pharma.
Yeah, interesting. I feel like this was like a lot of the peptide stuff came on the scene like 24 months ago, 18, 20, like, is that about
Yeah,
right?
there's a big
I mean,
surge.
yeah. Well, how far
Yeah.
have we scratched the surface on this?
Again, that information's hard to find because there's very little research. The most research we have is on BPC 157.
Yeah.
But what compounding pharmacies will do, let's take for instance BPC 157 that came off the market. They will then take that similar molecule, that peptide, and tweak it or take off an amino acid or whatever and then market it that way. And so there's just this ever rolling catalog, for lack of a better term, of peptides to try and get around some of that.
Interesting.
Yeah, so it's kind of this game that gets played, unfortunately. But it's as long as you're going through a good compounding pharmacy, I believe the risk is low. And of course, I'm prescribing the ones that I feel comfortable with and I'm familiar with, that has dosing recommendations, known side effects, that kind of stuff. I'm prescribing those.
Yeah. What's the normal course of treatment for a peptide if there is such a thing?
Yeah, it depends on the peptide, but so for something like BPC or Wolverine, you can be on that indefinitely. So the ones that have an effect on your hormone levels or your growth hormone levels, I do like to have you cycle on them. So 3 to 4 months, depending on the pep, before taking a break. And that's just to prevent your body from shutting down its own ability to make it. Same kind of theoretical risk with testosterone or any other hormone we're replacing.
Yeah, got it. So who should what would be a reason or like a set of reasons or symptoms that people would come see you for a peptide?
I see a lot of patients requesting Wolverines, whether they had a recent surgery or they're going in for a big surgery. A lot of people use it for lingering tendinitis. Again, I use it quite a bit for GI dysfunction. So that's, if I'm not seeing them from anything else and they're requesting a peptide, it's usually pretty much Wolverine.
Hmm.
Because with the secretagogues, again, I typically recommend that you're on hormone replacement therapy, testosterone, to build off the benefits of that.
Got it. How long is it until somebody sees the benefits, or do they notice the benefits of a peptide?
Yeah. So the cycles are 3 to 4 months. You typically start to see results about halfway through that
Okay.
because you're building up your growth hormone levels. And some people may not notice a ton of results in their first cycle, but then when they return to their second cycle, they may see better results there because, again, you're building off increasing your levels.
There's so much to dig into. I think I wonder if we should just keep looking at these things over a course of a couple episodes,
Yeah.
because there's a
Yeah.
lot.
There's a lot.
Anything else?
And I
Sorry,
think
go ahead, Sarah. That's
it's,
perfect.
yeah, no, I think there's a lot more conversation about it, which I think is great for people looking to more alternative type medicines or just overall, wellness and anti-aging. I think that's why there's such a big boom in it, because there's a lot of anti-aging, not even just cosmetically, but physically for your body and healing, and preventing illness.
Yeah, that is funny that you had to clarify that, because that's immediate. When I hear that, I think cosmetics.
Mhm, mhm.
I'm personally really excited about I'm going to say performance, but that's not really necessarily what I mean either. It's more about the
Yeah,
enjoyment and fulfillment of a long and healthy life, and
right.
these medicines or supplements or whatever they are, they can exist to help you regardless of how you look, which you might look
Mhm.
better too as a side
Yeah.
benefit.
No, it's a great benefit. Yep. There's one kind of specifically more geared cosmetically. It's the copper peptides, so GHK. And they're actually putting that in with Wolverine for additional collagen benefits. Because you've got collagen receptors all throughout your body. So yeah, they're using it. More women request that one than men, I would say, but either would benefit.
Yeah, sure. And I'll just probably start asking you in secret now because they're too embarrassed.
Don't tell my wife.
Also, can I get that other one? It needs a cool name like Wolverine, and then it'll be all over the place. It'll be great.
Right.
Okay, where can people find you?
So our website is revivalwellnessclinic.com. From that website, you can book at either location or call either location. We're also on Instagram. And you can get that link from our website as well.
Awesome. And we
Yeah.
do have a handful of people who are not local. I'm assuming you don't treat remotely, or do you?
I have a license in Washington,
Okay.
so I can treat people in Washington, and we'll be looking into Montana.
Okay, awesome. If somebody's not in either of those states or our state, what would they look for in a good practitioner or clinic?
That's a good question. So, like myself, because this isn't, unfortunately, at the moment, it'll maybe change in a few couple decades in the future.
Just just turn to the calendar.
Hormone replacement, isn't taught in our traditional schooling very much. I remember having half a day in women's health about it. So unless you specialize, you're an endocrinologist or something like that, it's not, oftentimes you don't go to your primary and say, hey, can I get hormone replacement? There's very few that are comfortable with it. So finding, a clinician who accepts insurance and is comfortable with hormone replacement is pretty hard to find. They're out there, but so oftentimes people are reaching out to clinics like myself who do not take insurance. And you can certainly get your hormone replacement care, through that too. But through Western medicine, you're never going to get access to peptides. And so finding a clinic that kind of does all of them, depending on, again, what your goals are, I would look for a private practicing clinic that focuses on wellness. And of course, through their website, hopefully they have one, and they list their services, you can tell what they feel comfortable treating.
I have
Yeah.
tended to hear some, not horror stories, but like it seems a little like there are outliers where they are
Sure.
just going to provide massive doses to.
Yeah.
Is there a
That's a hard one to kind of weed out. I think it would, you would get a sense when you sit down with that clinician, because I have heard that actually from a couple of patients transferring from another local clinic with that same concern. Like, I just want a reasonable dose for me. I feel like I was getting overdosed. And okay. So sit down and have a discussion with your practitioner and ask them how they treat, how they start with their protocols. It should always be low and slow with hormones, not to overwhelm your body, to prevent unwanted side effects, that kind of thing.
Yeah, think I can answer that a little bit from my own perspective, in that, like, if you're trying to start at another gym and they're promising you this life change, like tremendously life turnaround in a short period of time, I would run the other way.
A little sketchy.
I would
Yeah.
rather say, what I try and tell people is, I want you to be here for another 50 or 60 years. And like, it's my job
Mhm.
to provide the experience and recommendations for you that will allow for that. You can say that all you want, but I think hopefully it'll
Sure.
ring true or be authentic by whoever you're talking to, by asking the right questions and
Right.
talking to someone like yourself who obviously has that intention in mind. So
Right. Yeah. And yeah, I think especially people looking in the hormone replacement world, they kind of generally have an idea of what they're seeking. So, or have an idea, especially guys, they talk to other guys and, oh, what's your dose and what's your dose, and they can kind of see and gather information. I see a lot of that too, like, my friend's at this dose. Is that what I would need? Well, we'll see. You are you. You're not your friend. So we have to, your treatment plan is your treatment plan.
why is that so hard for people to like? That is such a challenge, right?
Well, maybe yes and no. I mean, a lot of medications that we prescribe have a set dose. I mean, and that's it. So blood pressure medications, you take either 20 or 10 milligrams, and it's not based on anything else other than usually how you're responding to the medicine. But I when I explain that to patients that I'm not using a cookie cutter protocol, this is your protocol, they tend to appreciate
Yeah,
it.
totally.
Yeah.
But I think people can't help but look in the lane next to them and wonder what what that person's
Right.
doing, and if they're
What, yeah, what do you want? Yeah, totally.
like, that's them.
But
This
that
is you.
person might have had a different level to start with than you do. So
Right.
I don't know.
Exactly.
So yeah.
Sarah, this has been a ton of fun and information, and I'm very appreciative of your time, and
Awesome. Yeah, ditto.
yeah, and I would
Thanks
love
for
to do
having
it
me.
again. And
Yeah.
I think we told people where to find you so they can go
Yes,
chat
perfect.
with you.
Thank you.
So
Love to consultations are free. Always usually like to start with blood work. So, and I'm happy to, go over previous labs and kind of give you my interpretation. It's always worth a discussion, always.
love it. That's
Yeah.
awesome. Well, thanks again, and
Yes.
I'll talk to you soon.
Sounds good. Thanks, Kenny.
Thanks, Sarah.
Bye.
Guys, thank you for listening. I hope you enjoyed that immensely, like I did. I feel like I learned a lot, and also just got to know Sarah, who is clearly a comfortable source of information that is happy to answer questions about the topics that I think a lot of people are curious about. So you know where to find her. As she said in the podcast, revivalwellnessclinic.com. You can book an appointment, a free consultation with her, and go from there. If you want to decide you want to go that course, or you want to do something before that and you are not a member at our gym, I definitely would recommend doing fitness and nutrition in conjunction, or as a preface to what Sarah can offer, and we can help with that. So find us at sandpointstrength.com, or you can just email me directly at kenny@sandpointstrength.com. See ya.